Welcome to the presentation. My name is Victor Cotton. I'm an internist and an attorney from Hershey, Pennsylvania. And my topic today is to address some of the ethical and medical legal issues that arise when we implement a genetic testing program. And my goal is to provide a framework for addressing those issues. I've built a presentation around a case. It's a fairly straightforward case of a 60-year-old man who comes in with newly diagnosed prostate cancer. And what I want to talk about are the things that we would do in evaluating and working up this patient. I think we'd all agree that we would review his biopsy, measure his PSA, get a Gleason score, perform a DRE, some other imaging studies. We'd estimate his life expectancy. Most of us would do molecular testing of the tumor to determine its level of aggressiveness. And the questions I want to ask are, would you take a family cancer history to see if anyone else in his family has cancer? And I think most clinicians would say, well, it's a little late for that. He already has cancer. Okay, what about germline genetic testing? I'm not talking about testing the prostate tumor. I'm talking about drawing a tube of blood and seeing if he has an underlying genetic mutation that would have caused this prostate cancer. When I ask that question, many urologists will answer by saying that they first ask if the patient has any sons, with the thinking being that although we cannot prevent this patient from getting prostate cancer, if he has a genetic mutation that he passed to his son, we could step in and potentially prevent the son from getting prostate cancer. That is a legitimate reason for doing testing. On the scale of importance, I rank it as the third most important reason. And frankly, if you're going to use that as your only reason, it's more important to ask if he has any daughters, because the risk of a genetic mutation poses a much greater risk to a daughter than it does to a son. Women are much more significantly impacted by genetic mutations than are men. But that is a legitimate reason to do genetic testing. I think the most important reason is because genetic testing can impact our management of the patient's prostate cancer. And I think the second most important reason is that we want to make sure the patient does not have a high risk of an associated or related cancer, because that could put us in an unfortunate situation of doing a fantastic job on his prostate cancer, only to have him die of a related and potentially preventable cancer several years later. So there are three reasons to do genetic testing. The number of patients impacted here is significant. If you look at the percentage of cancers that are caused by underlying genetic mutations, about 1 in 7 prostate cancer patients has an underlying mutation, typically in a BRCA gene, that has caused their cancer. Interestingly, the percentage of prostate cancer that's related to a genetic mutation is actually higher than the percentage of breast cancer that's related to a genetic mutation. Of course, there's a significant difference in awareness. Every woman who has breast cancer is aware of BRCA, but few men who have prostate cancer have ever heard of BRCA. And unfortunately, that awareness is also less than ideal among clinicians, but it does not change the fact that this is a very common phenomenon in patients who have prostate cancer. Now, back in the beginning, I said that genetic testing can affect how we manage a patient's prostate cancer. And I said that because patients who have BRCA mutations have a more aggressive form of prostate cancer. And when we look at the recommendations for managing those patients, for patients who have localized disease, the NCCN guidelines recommend that if they have an associated BRCA mutation, a germline mutation, that they're at increased risk of progression and decreased overall survival. And as a result, the current recommendation is that they be considered for enrollment in a PARP inhibitor clinical trial. For patients who have metastatic disease, they face a similar problem, and the recommendation is that they be considered for early use of cisplatin therapy. And this is because a positive BRCA mutation can have such a significant impact on their ultimate outcome. Based upon the impact that it has on these patients, the current NCCN recommendations are that germline genetic testing be done on all of the patients in the higher risk categories, and that it even be done on patients in lower risk categories if their family history is positive. So this then brings up the question of what is a positive family history? How do we define that? On this slide, I've outlined the criteria for a positive family history. What we do is we start by looking at both sides of the family tree, which is a little counterintuitive because what I'm saying is that your patient who has prostate cancer could have inherited that risk from his mother. So we look at both sides of the family tree, and we look at first and second degree relatives, which is brothers, sisters, mom, dad, and grandparents, but not cousins. And what we're looking for on either side are 3 breast cancers and or prostate cancer. So if on mom's side of the family you've got 2 breast cancers and 1 prostate cancer, that meets criteria. That's a positive family history. You can also have a positive family history by having any one of the following: ovarian cancer, pancreatic cancer, male breast cancer, female breast cancer under age 50, a family history of a BRCA mutation, and Ashkenazi Jewish ancestry. Now, I put Ashkenazi in parentheses because I don't want you to mistakenly think, as I did, that the Ashkenazi Jews were some small sect of Jews somewhere in the world. In fact, 97% of Jews are Ashkenazi Jews. So this is the Jewish population. The other thing to note on the slide is it does not say that you have to be Jewish, simply that you have to have Jewish ancestry. If your grandmother fled Poland as a Jew in the 1930s, you would be considered to be of Jewish ancestry, even though you personally are not Jewish. Now, why do we make such a big deal about this Jewish thing? What the slide says is, if you have prostate cancer and you have Jewish ancestry, you automatically meet criteria. What's the big deal with that? The reason is that the pathogenic BRCA mutations are 10 times more common in the Ashkenazi Jewish population. The rate in the general population is 1 in 400. The rate in the Ashkenazi Jewish population is 1 in 40. I said that these patients were also at risk of second cancers, and this was another reason to do genetic testing. If we look, the primary cancers that they're at risk at are breast and pancreatic cancer. Now, if the patient happens to have Lynch syndrome, which is somewhat associated with prostate cancer, the number of second cancers expands to include the colon and the GU tract. But for the most part, most of these patients are going to have BRCA or ATM or PALB2 mutations, and our primary concern is going to be breast and pancreatic cancer. In terms of percentages, the lifetime risk of breast cancer for these men would be about 7%, which is slightly below the average woman. And the lifetime risk of pancreatic cancer would be about 35%. And as a result, the recommendations here are that these men undergo yearly mammography to detect early breast cancer. And in many centers for pancreatic cancer, they would be followed with CA-125 levels as well as periodic CT scans. Now, a common question I get here is, if I discover a BRCA mutation as a urologist, am I legally obligated to order a mammogram and an abdominal CT scan and follow these patients? Of course not. What you are legally obligated to do is to make the appropriate referral, just as you would if you discovered that your patient was anemic or hypertensive and required some follow-up. So the mere fact that we find a pathogenic BRCA mutation does not obligate us to assume care for this patient's risk of breast cancer, we would manage that in the same way we would manage any abnormality that was outside our specialty. We would make the appropriate referral. Now, as a word of caution here, because genetic testing is beneficial and recommended by the guidelines, there is an associated legal risk in not doing it. The OBGYNs learned this the hard way, in this case from Connecticut. So let's look at it and see if we can learn from their mistake and hopefully avoid this mistake. This case involved a 45-year-old woman who met criteria for germline BRCA testing based on her family history. In other words, her family history was positive. Unfortunately, her gynecologist did not realize this and didn't recommend testing. She subsequently underwent a hysterectomy for uterine fibroids, and because she was premenopausal, her gynecologist left her ovaries behind, which if he had known she was BRCA positive, he would have removed because her risk of ovarian cancer was about 50%. Unfortunately, about 4 years later, she developed ovarian cancer, was found to be BRCA positive. She eventually died of that cancer. Her family filed a lawsuit. And my question here is, what are the viable defenses if we get caught in this situation? And the answer is that there are two. The first one is that we offered testing and the patient declined it. And the second is that we offered testing, but the patient couldn't afford it or didn't have the insurance coverage for it. So if you're in either of those situations, please document that that in fact occurred. The patient declined it or couldn't afford it, because otherwise these cases are very problematic. We're dealing with a simple blood test that's recommended by guidelines and a high stakes disease here like cancer. These cases are hard to defend, expensive to settle, but easy to avoid. Returning to our case, let's suppose you do genetic testing on this patient and he's found to have a BRCA2 mutation, which is the most likely mutation associated with prostate cancer. And you also learn that he has a brother, a son, and a daughter. What is our obligation to these people? Well, ethically, we feel compelled to do something to tell them that they are at risk, because if he has a pathogenic mutation, these are autosomal dominant conditions, meaning that his first-degree relatives have a 50% risk of also having the mutation. So ethically, we feel compelled to say something, although of course HIPAA restricts our ability to do so. What's our legal obligation in these situations? Well, we could start by saying that these people are probably not our patients. And if you're not my patient, then I don't have any legal responsibility to you. That's a good general rule. If someone's not your patient, you typically have no legal obligation and face no malpractice exposure. However, our courts have made several exceptions to this rule, and this is one of them. There are two big cases here, one from Florida and one from New Jersey. My sense is every court in the land would follow their reasoning, and both courts held that in this situation we do have a legal obligation to warn these people, to inform them that they are at risk. Fortunately, both courts said that we can do so simply by educating the patient and asking him to share the information with his family members. Hopefully he will do so, but that is not within our control. So if you're in one of these situations, make sure that at some point along the way you have this conversation, ask the patient to share the information, and document that you did so. Germline genetic testing offers a number of benefits to both the patient and his family members. I want to finish the presentation by talking about 3 issues that you're likely to encounter when you implement a testing program. They are variants of undetermined significance, healthcare insurance, and lab accuracy. When you receive a genetic test result, most of the time the result will be negative, meaning that the patient does not have a pathogenic variant. In about 5 to 10% of cases, you will receive a positive result, And occasionally you will receive a VUS, which means we don't know whether it's positive or negative. Now, a reputable lab will do further analysis on this and attempt to discern whether it's positive or negative. However, that process can often take several years. What we want to remember about VUSs is that most of them will eventually be reclassified as non-pathogenic, and that's how we should manage the result. VUSs are not clinically actionable. In other words, we treat them as if they're negative. We follow them. We do not intervene as if they are positives. And I emphasize this because when you first get into this, it's easy to err on the side of treating a VUS as if it's positive, but in fact, you should not treat it and manage it as if it's a negative. The second issue relates to healthcare insurance. 15 years ago, if you did a genetic test and found a pathogenic variant, the patient's healthcare insurance company could discriminate against him and alter his coverage in a negative way, and they could also do that to his family. As a result of this, some patients and some clinicians are still skittish, and they worry that if they do genetic testing, they could negatively impact both the patient and his family's healthcare insurance. Fortunately, this is no longer an issue because there are two federal laws which make this practice illegal. Both the Affordable Care Act and the Genetic Information Non-Discrimination Act make it illegal for a healthcare insurance to discriminate against a patient or his family or anyone based upon the results of a genetic test. And we can therefore confidently reassure patients that this is not anything that they have to worry about. My final point relates to lab accuracy. And to provide some background information here, when I first learned about BRCA, I thought it was a single mutation that you either had or you didn't have. But in fact, this complex of the BRCA genes has more than 10,000 variants, about 1,000 of which are pathogenic. The process of identifying these variants was patented by Myriad back in the 1990s, and as a result of their patents, they had an exclusivity and they became quite proficient at identifying BRCA variants. Those patents were invalidated in 2013, opening up the door for what I put in parentheses as generic competition. And the reason for the parentheses is that this is not really generic in the sense that we think about it with medications. And the reason is that genetic testing is not regulated by the FDA. It falls under CLIA. The specifics of that you don't have to worry about. The most important aspect of it is that CLIA does not require any demonstration of substantial equivalence. Now, when a drug goes generic and someone wants to market a generic version, they have to prove to the FDA that their version of the pill is substantially equivalent to the name brand version of the pill. That does not exist here. Nobody is assessing labs for their accuracy or their equivalence to any standard. Each lab does genetic testing in accordance with its own standards, and you can immediately see the problem this creates. We're scanning the human genome with a background of thousands of variants and attempting to pick out the pathogenic ones. With each lab doing it its own way and nobody refereeing the results, there's the potential for significant lab-to-lab variation. And in fact, it's not just potential. Since this generic phenomenon occurred about 5 years ago, there's been a number of papers come out showing a substantial rate of discordance. On the far right column are the percentages of time that the labs disagreed as to the result. So what I'm saying here is that the lab that you use can affect the result that you get. And this can obviously have a significant impact on patient care. If somebody says it's positive and someone else says it's negative, somebody has to be wrong, and that means there's a potential for a disastrous impact on patient care. It's hard to believe that this exists in the American medical system where everything is so heavily regulated, but at least for the foreseeable future, it does. We have to respond by making sure that we use a very reputable and reliable lab. Genetic testing offers us an opportunity to greatly improve care for both the patient and his family. Concerns about healthcare insurance are a non-issue, but lab variation is a very big issue. And I thank you for listening to me today.